And thank you organizers for inviting me. So the topic which has been given to me is early stage lung cancer, and I'll be talking about the adjuvant chemotherapy. And at the outset, I would like to say this was also a learning experience for me, because we all know in the era of adjuvant TKIs and immunotherapies in lung cancer, we hardly read about the landmark trials. So what I'll do is I'll take you through the how the chemotherapy has evolved in the curative NSCLC setting, and what are the few of the landmark trials which have been done in the 90s and the early 2000s. First of all, I would like to take from where the idea or the motivation to do trials or to introduce adjuvant chemotherapy happened. That was in 1995. This was a meta-analysis in BMJ, where they evaluated 52 randomized clinical trials. And the objective of this trial was to study the effect of chemotherapy on overall survival in NSCLC patients. And close to 9,400 patients were evaluated from these 52 randomized trials. And if you see the variety of chemotherapy regimens starting from 1965, the recruitment of the included trials started from 1965 onwards till 1986-88. And you can see all kinds of chemotherapies which were available at that time were used, be it cyclophosphamide, methotrexate, lomustine, doxorubicin, mitomycin, and their combinations. Then later on, 80s onwards, cisplatin came, and then they started using cisplatin with all the chemotherapies available. And talking about the results, so they took compared adjuvant chemotherapy with different arms. So one was surgery versus surgery followed by adjuvant. One was surgery plus radiotherapy followed by adjuvant chemotherapy. One was radical radiotherapy versus radical radiotherapy followed by adjuvant. Across all the subgroups, the maximum benefit was seen with cisplatin. What they observed was among the chemotherapies, also cisplatin had the greatest benefit, which was 5% at 5 years. So this gave them the hope, the idea that cisplatin might be beneficial. And if you see, I don't know if pointer is working. If you see the upper row, the long-term alkylating agents, in fact, they were detrimental. So there was not much hope with chemotherapy, and the surgery was only surgery was the standard of care. And if you read the conclusion, if you can read it very beautifully, what they have mentioned is, at the outset of this meta-analysis that was published in 1995, there was considerable pessimism about the role of chemotherapy in NSCLC. And the results of this meta-analysis offered some hope of progress and suggest that chemotherapy may have a role in treating this disease. You can imagine this was just 3 decades back, and within 30 years, we now know that not only chemotherapy, but now targeted therapies and immunotherapies have come a long way. So you can imagine the progress which systemic therapies have made in lung cancer, especially early lung cancer. So jumping on to 2004, the first trial which was published regarding cisplatin, using cisplatin based adjuvant chemotherapy, and which was positive. This was the landmark international adjuvant lung cancer trial. The recruitment started somewhere around the meta-analysis was published in 94-95. So this is the trial design. They took up to stage 3 patients, and post surgery they randomized them into chemotherapy versus observation. Radiotherapy was optional depending on the end stage, and in chemotherapy they had a cisplatin backbone along with something else. So it was either etoposide or vinorelbine or vinblastine or vindesin. The permanent partner was cisplatin. Talking about the results, the 5-year survival was 44.5% in the chemotherapy arm versus 40.4% in the observation arm, with an absolute improvement of 4.1% at 5 years, with a hazard ratio of 0.86. So this trial basically established that cisplatin combination therapy is the standard of care in adjuvant setting in the early stage lung cancer. A year later, another trial was published. Again, recruitment started somewhere around 94-95. Again, they only used cisplatin vinorelbine versus the observation, which was the standard of care in that decade. This is the JBR10 trial, and talking about the trial schema, what they did, they excluded stage 3 patients. They only took stage 1B and stage 2 patients, and they randomized them in vinorelbine cisplatin, which was the experimental arm, versus observation. They slightly modified the doses of vinorelbine because, as per the earlier trials, the earlier vinorelbine doses which were used were pretty toxic, and they also split the cisplatin into day 1 and day 8, because in the earlier trials, as you have seen, that it was 100 mg per meter square on day 1. Talking about the results, again, significant advantage statistically as well as clinically significant advantage in the overall survival. If you see on the left hand side, in the overall population, the median OS was 94 months versus 73 months. And if you talk about the 5-year OS, the absolute benefit was 15% in the experimental arm versus the standard of care arm. Obviously, the stage 3 patients were excluded. Most of the all the patients were stage 1B and 2. And if you talk about stage 1B and 2 separately, you can see the stage 1B, the difference was not significant. So whatever benefit was there was seen in the stage 2 patients. A year later, again, so every year one or the other trial was coming. So in 2006, the Anita trial came where they evaluated cisplatin vinorelbine again versus observation. And here they took stage 1B to 3A patients. Again, randomized into cisplatin vinorelbine versus observation. Talking about the results of this trial, again, it was proven that cisplatin combination is beneficial both clinically as well as statistically. And in this trial, the median OS was 65 months versus 43 months in the observation arm, with a 5-year OS delta of 8.6%, and in the long-term results, 7-year OS delta of 8.4%, which was very, very clinically significant in that at that time. So this basically established that cisplatin combination is the standard of care, and all of the trials used 4 cycles of chemotherapy. Then there were some other trials also. One of them was CalGB 9633. Here they used adjuvant paclitaxel in stage 1B non-small cell lung cancer. So they only took stage 1B patients and they randomized them into paclitaxel versus observation arm. This trial overall was negative. There were some drawbacks or criticism of this trial, that it was not powered enough for detecting small differences. And another thing was they took paclitaxel carboplatin, which was already proven in 2002 as an inferior regimen as compared to paclitaxel in the metastatic setting, but still they used. However, despite being a negative trial, what they saw that even with paclitaxel carboplatin, in the subgroup of, you can see the C graph, in the subgroup of patients who had a T size of more than 4 centimeter, the chemotherapy did benefit despite being an inferior regimen. So this again gave a confidence that more than 4 centimeter we should give chemotherapy combination. So summarizing the adjuvant chemotherapy trials, the IALT supported the platinum-based chemotherapy regimens. The BR10 had the maximum benefit in overall survival, and the CalGB, although it was a negative trial, but they saw that the risk of death was found to be lower in a particular subgroup of patients. And Anita obviously again showed that overall survival and as well as DFS was significant. Then came the LACE meta-analysis in 2008. We know that this is the landmark meta-analysis of all the adjuvant chemotherapy trials. 5 of the largest trials they took, close to 4,580 patients. All were cisplatin-based chemotherapy combinations, unlike the earlier meta-analysis of 95.
Satvik, last 2 minutes.
Yes, sir. I'm almost finished. So the trials which were included are JBR10. Then there was the Nevelbine trial, the adjuvant lung trial, and big lung trial was also there, although this was a negative trial. And you can see the chemotherapy benefited as per this meta-analysis. OS as well as DFS benefit was there in the chemotherapy arm with a significant hazard ratio. And if you talk about the 5-year OS benefit, in the OS there it was 5.4%, and in DFS it was 5.8% 5-year DFS benefit. So this basically stamped, this meta-analysis basically stamped that chemotherapy is required and it is beneficial in terms of overall survival as well as DFS. Lastly, again, a meta-analysis was performed which was published in 2010 in the Lancet. They also showed, they compared surgery versus surgery plus chemotherapy, and surgery radiotherapy versus surgery chemotherapy and radiotherapy. And both of them, you can see there was 4% benefit on overall survival at 5 years. So the last slide concluding that the adjuvant chemotherapy definitely improves outcomes in patients with completely resected non-small cell lung cancer, as we have seen in the trials as well as meta-analysis. The 5-year survival rates vary from trial to trial, but most of them had 4 to 5% benefit, with 15% going up in the one of the trials where they only took up to stage 2 patients. And cisplatin plus vinorelbine has been the most widely used, widely studied chemotherapy protocol. So whenever possible, give this. But obviously, NCCN recommends many chemotherapy regimen nowadays. And 4 cycles of cisplatin is the preferred, is the recommended regimen, with cisplatin vinorelbine being the preferred agent. Thank you.